Well, hello everyone. Thanks for joining. We've got what should be a great talk today from Paul Pfeffer from Barts. Just quickly to say, obviously, when you join, please make sure you're muted. Camera on and off is entirely up to you. And the session will be recorded with all the details and slides of Paul. And someone's already asked Paul to include his email in the chat, which I think he has already done. It's in there under PP. So yeah, without further ado, I'll hand over to Paul. Thank you, Paul.
Thank you for inviting me. If everyone just mutes themselves, I'm going to get these slides up. Rebecca Taylor is going to be joining us and presenting a couple of the slides.
I'm here.
More face. Hello.
Hi.
Face side. There's a small chance we may be interrupted by a small child, in which case I apologise. They're not meant to be presenting anything. So what I'm going to present is the Barts Health after COVID service, and in particular the pathway, and it's quite complicated. For those of you who don't know me, I'm a consultant respiratory physician and clinical academic at Barts Health in QMUL. My interest is in asthma and severe asthma. I have some pharma funding as below, but none of that is at all relevant to this talk. The aims of the session have grown, which you can see on this list here, and they have grown since I produced the slides. I'm going to attempt to cover everything, but there's 20 minutes of questions at the end for anything we haven't managed to cover. But I'm going to start talking a little bit about acute COVID and the actual clinical disease and what we know about it. That's more of a scientific talk, but it should be quite quick. But it lends itself nicely to then talking about the after COVID pathway. So first of all, COVID-19, an overview of the acute presentation. So I think most people have seen plenty of cases, predominantly male patients, slightly older, cardiovascular risk factors, coming in with cough, fever, fatigue, diarrhea, having those symptoms for a good 5 to 7 days, and then sort of at that point starting to really deteriorate, but with very non-specific symptoms. They come into hospital profoundly hypoxic with saturations in the 80s, but actually they don't report as much breathlessness by any means as you would expect. The X-ray shows bilateral lung infiltrates, lymphopenia, and that's really quite non-specific for viral pneumonia. Raised ferritin as an inflammatory marker, D-dimers again as an inflammatory marker, but there's this crossover with pulmonary emboli, and then a raised troponin that we don't quite understand, and that's a key note that I'm going to come back to. So what is treatment? Well, actually, in some senses, it's a very easy disease to treat, because all that we really have had for the first wave is oxygen and anticoagulation. There's been lots of talk about antiviral, remdesivir in particular, and anti-inflammatory treatments, which I'm going to talk about in a minute, but those weren't really available for most of the first wave. And as anticoagulation is fairly simple, for much of the time the ward rounds felt a bit like the Grand Old Duke of York. You would put the oxygen up, you'd put it down, you'd put it up again and down again, and slowly over time patients would either improve or get worse. So here's a schematic of the typical journey of a patient. The first 5 to 7 days was very similar between every patient. Most of us who have had COVID in the community have improved by 7 days and we're much better. But a proportion of patients acutely deteriorated, and this is very different from the post-COVID complications. Proportion acutely deteriorated. These patients had a need for oxygen. They felt fatigued, but actually they were hypoxic. Even in the community, they were generally hypoxic, just less so. Easy to ventilate. It was a type 1 respiratory failure. And again, most of those patients after another 5 to 7 days improved. Those patients were largely in hospital, but also many in the community at that stage. The ones who didn't improve at that point are the ones who then came into hospital if they hadn't done so in the first step. And at this point, they really had profound ventilatory failure as well as hypoxemia. Difficult to ventilate, going to ITU, multi-organ failure, kidney problems, some cardiac problems, clotting, really an ARDS, multi-system disease. But these key checkpoints as if within the disease history. And that was our local impression and very much fits with a history from China right from the beginning. This is the story of 2 patients from Wuhan right back in January, February, and again showing 5 to 7 days of non-specific symptoms, then deteriorating with breathlessness, needing oxygen, and then a second deterioration again 5 to 7 days later, going to intensive care and developing multi-organ problems. The fascinating bit is throughout this period, they are generally viremic. They're positive for the virus. Now, the really interesting thing about that particular phases of the disease is it tells us a lot about treatments. So the interest very much has been internationally and in America particularly about remdesivir as an antiviral. It's a drug that interferes with the viral nucleic acid synthesis, stops the virus replicating. There's been a lot of talk about it, and I know these slides are quite difficult to see, so I'm going to explain them quickly. They're Kaplan-Meier plots looking at time for clinical improvement. The red and the blue bars represent remdesivir and control, and the left-hand side is people who start remdesivir within the first 10 days, and the blue side is, the right-hand side is people who don't. And the bottom line of what these graphs show, in this study and other studies, is remdesivir doesn't have a massive effect, but only works if it's given early. If you give it in that first phase, really, it will work. If you give it after 10 days, there is no point. So the patients are still viremic, but the pathology after 10 days isn't primarily due to viral replication. Opposite, in a very sense, is true of dexamethasone. So this is data from the UK recovery trial, looking at giving dexamethasone in hospital to people with COVID. On the left-hand side is people not requiring oxygen. So these are the milder patients or the patients very early on in the disease. And actually, they do worse if you give them dexamethasone. Whereas if you give the steroids, the immunosuppression to people in the later stages requiring oxygen, and particularly if they're going to ITU, they do much better with dexamethasone. And the combination there very much suggests that remdesivir is good for suppressing viral replication early in the disease and preventing later problems. But if you get into the later stages, then it's dexamethasone and immunosuppression which is going to work. The remdesivir is a drug that's given intravenously and has got some side effects, so will never be given in the community. Dexamethasone could, but dexamethasone needs to be given to people who are requiring oxygen. So by that virtue, it's going to be a hospital treatment. So really, this doesn't advance our treatment that much. And if there's a second wave coming along, we don't have the capacity in the NHS to admit everybody at day one to give remdesivir. So all we've really got left is a bit of dexamethasone, which it has got a marked effect, but it still only reduces the mortality from 40% to 30%. So this is the current scientific schematic of the disease, a viral response phase, which actually sets you up for the later phase, but the viral response phase is not where the real danger is. And the danger is in the later host inflammatory response phase. And the further people go down this hyperinflammation, the more acute problems they end up with. And again, these key checkpoints. So really, what happens after COVID is the next question. We get these patients through, they've either been managed in the community, they've needed oxygen and come to a general ward, or they've got worse and they've gone to a respiratory high dependency ward or ITU. And the question is, what happens to them next? And the simple answer is, we don't know. So this is a key question. We're not sure what these complications are going to be. And the bottom line from that is the importance of cohorting these patients so we can learn, and we can learn from each other and treat them best. It's not quite that bleak. We do have a sizable amount of data from SARS-1 all those years ago and MERS, which are very similar coronaviruses with a similar presentation. And in SARS-1 and MERS, there's impaired gas transfer in patients in about a quarter to a third of patients at 12 months, particularly those requiring oxygen or ITU, with CT evident changes in many at 6 months. There are more general symptoms of tiredness, difficulty sleeping, myalgia, and muscular weakness and pain in many, many patients. Also PTSD symptoms and depression, and then hypocortisolemia, failure of the adrenal axis to really cope with everything. And the picture at the bottom right-hand side is not a patient who's had MERS or SARS, but it's actually how we know these patients are going to feel. They're going to feel awful. The distress of having been through this, and in many cases very breathless, is a big concern. So we sat down to design a pathway internal to Barts Health to what to do with these patients. And the top of my list and my colleagues was, worrying about deconditioning, basically loss of fitness, being breathless because the viral phase has eaten through your muscle mass. You've been in bed for weeks, and now really trying to do anything is very difficult. Breathing pattern disorders, which is a problem when the wrong sets of muscles coordinate your breathing. So you may get used to breathing from the top of your chest, the apex, during the acute phase because the lower part of your lungs are consolidated. And then you need to switch back to a normal breathing pattern as you recover. But some patients don't. And I often think it's a bit like trying to do the marathon running on your hands. It's not what your hands are designed for, and you're not going to do very well. So those are the two big ones I was worried about. Then my colleague Gavin Thomas, who does interstitial lung disease and lung fibrosis, was worried about that. Other colleagues about post-traumatic stress disorder, fatigue, and general post-viral constitutional symptoms. And then also the other major issue is many of these patients may have had another diagnosis when they came in. And with 1,200 patients coming in rapidly, there's a potential for things being missed. For example, an underlying lung cancer, as there's always the concern can be missed in any pneumonia. So this was the respiratory perspective. What we had was a big conversation across the hospital. So we involved people from probably a dozen different specialities, asking them what were they particularly worried about. And the pathway I'm presenting is a holistic multidisciplinary pathway designed to pick up every organ symptom we could think of when we wrote the pathway. And the real question that we were asked is, how do you safely follow up 1,200 or more inpatients who have had COVID pneumonia, most of whom will recover without problems, because actually many patients it was a mild disease, but many of whom will have profound post-COVID complications. And our question was how to do that in an exhausted NHS. And the hospitals really are still exhausted. And the hospitals are trying to catch up with all the work that didn't happen in those 3 months. And the patients don't want to travel. And this is the pathway that we came up with. So this pathway initially grew for discharged inpatients, but I'm going to explain how it relates to primary care in a minute. So the first thing is that patients who went home who we were concerned about would have had a telephone follow-up from the group who sent them home within the first 2 to 6 weeks. And that's been done on a very local level and is not part of the overall pathway. Whereas everything else I'm going to talk about is a trust-wide process. And the first problem we came to is that actually we couldn't code for COVID pneumonia for the first patients who came in because that code hadn't ever been written. So we've had to go back through every single patient to try and spot who had COVID pneumonia. We are nearly there, so we're up to some point in May. But there is a possibility that patients will have been lost. So don't be afraid to ring us up or email us and say, have you lost this patient? Because we'll be more than happy to pull them back in if they've been in hospital. Those patients should then be asked to do an X-ray at 10 to 12 weeks and complete an e-questionnaire. Now, we are slightly behind in this, so at the moment we're sending out the letter at about 12 weeks when we wanted to send it out at 9 weeks after inpatient discharge. We have tried to tell the patients in the discharge advice leaflet that this would be happening, but again, with the hurry of getting people home, not everyone got all the advice leaflets at discharge we hoped. What patients should be receiving at 10 to 12 weeks is this invite letter saying, please go for a chest X-ray at the following sites. The hospital has booked your X-ray, and please complete this questionnaire. The questionnaire can either be done online, but of course there's a big digital divide, so there's also a phone number they can ring, and people will do the questions over the telephone with them, and that is working very well. The questionnaires and X-ray are then looked at in an asynchronous virtual clinic. So we look at the questionnaires, which are going to come into the X-ray, the admission, and we decide whether people have recovered well, in which case they can be discharged with advice, and everybody is getting advice on their discharge letter and a second set when they get discharged from the pathway, or they come in for interventions, which I'm going to talk about in a few more minutes. So that's the pathway. So this is what the questionnaire looks like if you do it online. It talks you through the questionnaire, how this is part of a medical review. It's our standard of care locally. It's actually enhanced compared to what the national standard of care is, which suggests that patients who haven't been to ITU don't necessarily need follow-up apart from an X-ray, which we thought was inadequate. And then the patient does questions such as this. Do you have a cough at the moment? Yes or no? If you have a cough, is it getting better, staying the same or getting worse? And how severe is the cough from a scale of 1 to 10? We ask about breathlessness, cough, fatigue, difficulty sleeping, the same level of detail. We then ask it a bit less level of detail about sense of smell, joint pains, diarrhea, and another few multi-system questions. They then do the validated questionnaires for depression, PHQ-2, anxiety, GAD-2, and also the TSQ looking for post-traumatic stress disorder. Then a few questions around fatigue, and they also at the end have the opportunity to put in free text anything else they want us to know about. So there's always the opportunity for the patient to express something else that we haven't asked about, which we thought was very important. We then sit down in the virtual clinic with a computer and a guideline, which I'm going to come on to, and we look at these results, and that forms the basis of the virtual review clinic. So most patients don't get a telephone call. Most patients will just look at what they've already told us and the imaging, etc., and make a decision. Now, the guideline is quite long. It's a 29-page guideline at the moment, and it's a living guideline. So we're learning about these patients every single week, and we're revising it every single week, and that's written into the guideline. So actually, bits of it are changing, and that's one of the reasons we are releasing the guideline, but we're not disseminating it too much at this point because we're still trying to go through it. There's input from respiratory medicine, imaging, physiotherapy, critical care, etc. I'm not going to read it all out. But the idea is a multidisciplinary pathway to assess patients, and it's also its risk stratification. Who can be discharged because they've recovered well? Who hasn't, but actually is not that unwell and we can give a community intervention to, which we'll come on to, and who has got more urgent worrying symptoms that we need to call back for urgent review. We complete the virtual clinic on a power form within our system, which is very easy and quick for us to do, and make structured data so we can always recall patients if we need to. If we learn in 6 months' time something means something else, we can recall everyone very easily. And that automatically generates the letter. The letter goes to the patient with a copy to the GP. So it's all in a patient-friendly language, apart from there is the option at the bottom for us to make a specific comment in more medical terms. And it talks them through the imaging they had in hospital, whether there's any further concerns, for example, a missed lung cancer. The imaging on the X-ray, whether that's fine or whether we need to do any further follow-up. How we're going to manage their breathlessness and cough, other symptoms of a physical nature, mental health advice, and then another section we can free text back to the patient advice. And that is the clinic outcome letter. And in some patients, that is going to be the final part of the pathway because they've recovered well. We will send them additional information in any case to help with their recovery, but for others, they will need more after that. And I'm going to come back to what we do afterwards in a minute, but I'm just going to explain how the outpatients fall into this pathway. So again, the big question is we don't know what complications people are going to have had who have had COVID in the community and haven't needed a hospital admission. If they've had a hospital admission, they should automatically be picked up. And if you're concerned they haven't, please email the after COVID email address, which I put on the chat. But if they've only had COVID in the community, they could well have exactly the same problems. And actually what we're seeing is really many of the problems are identical, whether you've been managed in the community or not. So we're trying to make the pathway as accessible by people in the community. However, all the community referrals go on top of the 1,200 we've already got. So again, it's a risk stratification process. So the people with the most severe symptoms can get picked up first, no matter where they've come from. So again, they need an X-ray and to complete the online questionnaire. We have to complete the online, we have to onboard them. We have to request the online questionnaire here, and we will send them the invite letter. However, because of the way the radiology and the legal questions around radiology, we are grateful that you have to please request the X-ray. We are happy to follow up the result, but for legal reasons, we can't request the X-ray internally in the same way. So they have the X-ray in the questionnaire, and again, this will go into the virtual clinic, exactly the same guideline. Patients where we actually decide there is not a high-risk issue may be discharged with medical advice, but that's actually not really the case in people from primary care because they're being referred in because they've got issues, and they're going into the same interventions pathway, which I'm going to talk about now. Well, actually, first of all, sorry, I'm going to talk about the results from the screening questionnaires, and then I'll then talk about the pathway. So far we have had over 300 patients complete the questionnaires, of which about 25 are community referrals and about 275 are hospital inpatients who have been discharged. We think that's about a quarter of the hospital inpatients, so we have a long way to go, but this has only been running 3 to 4 weeks, so that's hundreds of patients a week, which is quite incredible compared to any normal pathway. What we weren't expecting is that actually nearly half of patients have significant residual symptoms at 12 weeks. And we had thought that by 12 weeks, many more patients would have improved and that we'd be able to triage out a larger amount of them. But there we are. What are they reporting? Well, actually, only a minority of the patients are reporting breathlessness. About 80 out of 300 who have so far answered. And if we look at the severity of the breathlessness they're reporting, very few are reporting severe breathlessness. In most cases, it's mild to moderate breathlessness, not particularly clinically worrying, although it's worrying for the patient, and we'll come on to how we're going to tackle that. But only a minority are we so worried about the devastating degree of the breathlessness that we bring them in. And we assess this through a few questions, not just this one here. Cough. Well, actually, very few patients have a cough. And again, most of the patients who have a cough, it's mild to moderate severity. And again, we have a plan for that. What the biggest issues that patients are reporting is fatigue, and not just mild to moderate fatigue, really profound fatigue at 12 weeks after the acute episode. And that's very concerning, and we're going to have to work out how to address that better than we currently are. And again, these are slightly different graphs showing for breathlessness, fatigue, and difficulty with concentration, whether patients report they're getting better, staying the same, or getting worse. And with breathlessness and fatigue, generally, they're getting better. But actually, difficulty concentration, most patients or many patients are reporting they're getting worse. And that is really a big concern because we don't know why they got the difficulty of concentration. And the fact they're saying it's getting worse at 12 weeks is concerning. And similarly, for joint and muscle pains, many patients, this is now on the far left, are reporting worsening symptoms at 12 weeks rather than improving. And again, that's a concern we're starting to address through this living pathway. The next 3 plots are representing TSQ scoring for post-traumatic stress disorder, GAD-2 scoring for anxiety, and PHQ scoring for depression. And these have been decided together with ELFT and the other primary care mental health teams as their preferred screening questionnaires for knowing who should be advised to access IAPS for psychological therapy. And actually, I have to say a smaller proportion than expected of patients are scoring what we would call a positive score indicative of likely PTSD, anxiety, or depression, as shown in the red bars. So putting it all together, and this is a complicated heat map, what it's trying to show you is that actually about half of the patients we know have problems, but actually the patients who have one problem are very likely to have 2, 3, or 4 problems. And actually we can therefore say that a good proportion are completely recovered, and there are other patients who have multiple problems, which is actually a bit more reassuring than if we found every patient had a problem. At least we know a proportion are improving, just not as high a proportion as we might have hoped for. And again, this is another plot showing very similarly, many patients have more than one problem, although some of them dissociate. So concentration and memory seems to affect different patients to musculoskeletal pains. And as we're not sure quite what is causing the musculoskeletal pains and what causes the memory and concentration, that's concerning. But there's going to be more analysis of this data as we come through, as we learn to understand it, so we can hopefully begin to tell you what this means in a better level of detail and recall patients if we need to, because it's structured data for that reason. So here's the key bit. What happens next? What happens once we've done these questionnaires? A proportion of patients are much better and they can be discharged. Many patients still need help. So what can we do? Well, the first thing we're doing is we're giving people advice leaflets, because actually, in many cases that patients need to rehab at home, there is not the capacity within any type of hospital rehab service to see everybody. So we're giving them quite detailed advice sheets, which I'll come back to, but they cover physical health and mental health, breathlessness, fatigue, cough, appetite, voice, and now we're writing more ones for things like musculoskeletal pain. These tell patients what they can do to help themselves improve. And the idea is that most of the patients with the moderate severe symptoms, we will then ring up in 12 more weeks to say, how is it going? Are you following the advice we are given? Are you improving? And this should work because we know the main cause of breathlessness from having seen some of the more severe patients, which Rebecca is going to talk about, is that actually it's deconditioning, loss of fitness and breathing pattern disorders, both of which can respond very well to self-managed physiotherapy. And then there's follow-up. So the patients with the most concerning are having an urgent telephone and then face-to-face. So actually, if the questionnaires are very worrying, within about 2 weeks, we'll see them face-to-face to see what's going on. The other end of the spectrum, some patients are being discharged with advice because they've recovered well. And then patients in the middle are getting a range of things, either 12-week later phone calls, face-to-face review, blood tests where we think it's appropriate, or where something during the admission may have been overlooked and they need some follow-up. Further imaging, for example, if they've got a suspected lung cancer, they'll go for further imaging. And at that point, we will plug them into specialist clinics. So, for example, lung cancer clinic or a lung fibrosis clinic. So the patients come through this and then being triaged into other services as needed. So this is the example of a breathlessness leaflet. It's quite long. I think it's now 15 slides long. This is an early draft. It covers mild, moderate and severe breathlessness, what to do, what to expect, why you shouldn't be too worried, how long it should take to improve, fairly specific exercises of what to do. So these are example exercises for people who are very breathless or fatigued, simply leg lifts while sitting, very simple exercises to start to rebuild their muscle mass, which then go on to the more moderate and then on to the more severe, or exercises for people who are fitter, for example, the step-ups and sit-to-stand tests. However, advice sheets are one thing, they don't replicate in-person pulmonary rehab, and we can't replicate in-person pulmonary rehab because actually asking people to travel is a big ask during COVID lockdown, and even now people are very scared to travel. And also we don't have the capacity. So what we're working on and what we're hoping we can release in about a week to 2 weeks time is an app. So we've made this app together with UCLP and Living With, who's a digital health company, and it's going to provide rehab following the advices in our advice sheets, but with more remote monitoring by clinicians. It's a trusted system that's already in use for other diseases within the trust and nationally. So I'm just going to talk you a little bit about the app. So the app is very personal. Patients will do very similar questionnaires, some daily, some weekly, some monthly. They'll be reminded what they need to do. That will give us the information on whether they're improving. They'll also be asked to set goals, and we can help them set goals of what to do. So, example, do 20 leg lifts this week. We can tell them that. They can set goals and reminders on their smartphone. That will then record their progress and again communicate it back to us. Daily exercises, etc. People will confirm also how breathless they get, because we don't want people getting too breathless. We want to make this very safe. Fatigue, this is a big issue that we need to still work on. At the moment, we're giving the occupational therapy, the Royal College of Occupational Therapy fatigue advice leaflet. That's very good in a general sense, but really post-viral fatigue seems to be a bigger issue here, so we're going to need to work on that. And the app has profound resources for helping with management of fatigue. And the key thing here is the patient can send us messages and we can send the patient messages. Now, the patients are warned that we don't read the messages all the time. So if they've got an urgent problem, they still need to go and access urgent care as they normally would. This isn't a Babylon Health type thing, but it helps us communicate with them and give the personal touch. And we have our own portal, which we should have up and running again, we hope within 2 weeks, where we can send those messages back on forwards. And also we can see how well they're doing. So we can look at all of our patients, say we've got 200 people under doing this. These 20 really don't seem to be doing well. We can't wait for 12 more weeks to see what's going on. We need to call them back. Whereas those 20, they've done so well, actually we can discharge them from the pathway at this point. So this is where we're heading. Now, it allows us to monitor the recovery of everybody in a very simple manner. We're hoping to use this. There's also a hope to build on this app, and we're going to need support from primary care there, because actually, as we learn, and particularly if we end up with a second wave, there's a big question as to maybe patients could access this app from primary care without waiting for secondary care referral. There's also the question of the digital divide. Now, with the initial triage questionnaire everybody does, there's the option of doing it by telephone. We haven't yet got the equivalent for this. So what we're hoping to go to is to Barts Charity, but we may ask for letters of support for this. For an idea that we've got is that actually people who can't use the app so well could have a peer, a mentor, somebody who may be younger in their family, who can all have a mentor version of the app, who can help guide them through it and do those remote reminders. If we go back into lockdown, families are going to be separated. There isn't the same peer-to-peer contact to help with this, but we're hoping the app can maybe help with that. But that's next steps, and that won't be ready in the next 2 weeks. But that's where we want to go, because many of these rehab issues are also not specific to COVID pneumonia. So for the patients with the most severe symptoms, we're bringing them into a multidisciplinary face-to-face clinic. And that's really where we're trying to learn from the patients and provide more interventions to help them. And those interventions we provide at the face-to-face level are again being mapped back into the earlier pathway so that all the patients can benefit. I'm going to hand over to Rebecca, I hope, who can going to present the next few slides.
Thank you. So I'm one of the locum respiratory consultants, and I used to be in Newham outpatients, and then I moved over to take over doing most of the clinical stuff of the COVID pathway. That's me in the middle of that picture. Paul is controlling my slides because I'm doing this on my phone because there's currently a face-to-face clinic taking part where I am at the moment. So the face-to-face clinics, we're based at Mile End Hospital, and patients have to travel to Mile End. There's no other option. We do 2 afternoon clinics every week on a Tuesday and a Thursday, and they're set up for 4 patients per clinic. They're in the building for about an hour and a half to 2 hours. They get seen by a nurse, a doctor, a respiratory physiotherapist, and a research nurse. They have blood tests taken and then chest x-ray if necessary, but most of them have had their chest x-ray or it's too soon if there's any further abnormalities. That's my physiotherapy colleagues on the photo with me. Next slide, Paul. Thank you. Just some numbers so far, just so that you can see the kind of work that we've built for ourselves. This is week 5 of the clinic, but these are numbers from the end of last week, and 226 patients have been processed through the pathway, and most of these have been hospital discharges. Very few of the GP referrals have made it as far as that part of the pathway. A third are being discharged, which is great, but a third, that means that 2/3 are unwell. And out of those, we're having to bring back about 14%, so 32 to the face-to-face clinic. And I'm also discovering from reading the GP referrals and the questionnaires that the patients are giving, they're understandably more complex than some of the simple ward discharges. So the numbers that need face-to-face are going to increase and be more than 8 a week, which is a challenge that we haven't quite worked out how to deal with yet. Apart from today, we're seeing 9 instead of 4. So we have very small numbers coming through this clinic so far. They're going to increase significantly, but from my point of view of what patients think about it, they really want to attend. Obviously, it's been very hard to access full medical care during the pandemic, and most other outpatient services are still phone calls, and they really like coming to see somebody. I think we've only had one person who's like, no, I'm not travelling to Mile End, I live the other side of Whipps Cross. Everything else has been no problem. They get to see really comprehensive assessment. And also from the psychiatric point of view, the leaflet is a self-referral, but there are a few that I've been completing for patients during clinic if I'm sort of think that they're not actually motivated enough to complete the form themselves. There's not much that we can really help with. A few of it sounds a bit like asthma, but are we just trying to find something that we can treat? There's no real magic answer for all of their symptoms. And just a comment about the CT component of the pathway. When we wrote them, we were very concerned that there was going to be quite a lot of missed PEs and other sort of COVID pneumonitis. And I've done, that number's out of date now, I've done 24 CTPAs, And we have found no pulmonary emboli 12 weeks on, even in a patient who sounded extremely high risk when I phoned her yesterday morning. She was saying, I've got significantly breathless, episodes of pleuritic chest pain. I've been checking my SATs and I go down to 80%, and I've been collapsing all over the place. She hasn't got anything on her CT to explain any of that. So, and quite a lot of the questionnaires that we're having completed by patients, the patients are actually saying, can I have a CT scan, please? And we're not finding much pathology. So that's something I'm sort of keen to let you know about. But we will still be scanning the ones that need it. And I think that's now back to Paul.
Okay, so I'm going to cover this one last slide and then try to wrap things up and address some of the issues already coming through on the messaging service. So this is really looking at the moment at 12 weeks. What's going to happen later? And this is the other big question. Why are these patients getting memory and concentration problems? There's musculoskeletal pain that in some patients is due to what we call prone positioning in hospital, but in other patients looks more like fibromyalgia. These patients had high troponins during their admissions, very suggestive of significant cardiac damage, and I mean significant damage, and yet they haven't presented that way, and we don't know what's going to happen later. There's a question mark whether that's due to an endotheliitis that may suggest they might have a vasculitis. Are some of these patients going to get lung fibrosis, secondary infections? These are all questions we are still tackling. And one of the key bits I want to try and express from this is that it's a learning pathway. So I'm really keen that we've done this talk today, and hopefully this will be the first of a few talks where we can go through aspects of the pathway, because actually as we learn from our cohorted individuals, we need to disseminate that knowledge, because we can't see everybody in secondary care. But the advantage of cohorting is we can really begin to understand what the issues are and spread that knowledge. So hopefully this will be the first in a series that we may hold to go through some of the specific issues as we learn more. But we're really learning together with you. We're just seeing patients in more of a bulk. The second thing I just want to go through, if my computer will let me, is the pathway. Just the key bits of the pathway. So we are going to be inviting every patient who's been an inpatient here, so not A&E, everyone who's been admitted to a ward across the whole of Barts Health will receive an invite at around 10 to 12 weeks, asking them to go for an X-ray and a questionnaire. For the patients who have been in hospital, we are requesting those. If you're concerned that we've missed a patient who is admitted to hospital, please email us at the aftercovid.bartshealth@nhs.net email address, and we will pick up any inpatient discharges we have left. If you want to refer people from primary care, please use the ERS referral. Please put the date of the acute COVID so we know roughly when 10 to 12 weeks is. And please request the chest X-ray yourselves. We will do the amplitude, the online questionnaire invite, and send that to the patient. And they will filter into exactly the same system, and they will be triaged as part of a common pool. We aren't prioritizing one group or the other except by symptom severity. Really, this is for COVID problems. So if it's a non-COVID issue, this isn't the right pathway. If there's a big concern about a COVID related problem before then please don't put them through this pathway, but you can email us and we can work out how we're going to manage it. I know I've heard about one person here who's got profound breathlessness at 6 weeks. It looks like this is more of an acute deterioration than a 10 to 12 week long-term issue. And again, they need to be seen, but that's not quite the right pathway. The reason we picked 10 to 12 weeks is that's based on the natural history and what we know about it, is that by 10 to 12 weeks, we would have expected people to have improved. If there's a 2 weeks after discharge, then it's more likely to be a different problem. We need to handle it a bit differently. For psychological things, we've worked with ELF and NELF, and people will go on to IAPS, which is all in the advice leaflets. I think one thing that's come across from the Twitter, well, the messaging feed is these are the same problems that are being seen in primary care. And yes, they are. And actually, no one has time to give these patients as much as they would like. We are seeing the most severe 5 to 10% face-to-face, because that's all that we have capacity to do. And that's the most 5 to 10% most severe from the community or from hospital. We understand the pressures everyone else is onto. The other 90% of the patients we're seeing are being managed just with the virtual clinic review, which is a very quick 10-minute process, or 20 minutes at most, to go through the data that we have. Hopefully what we learn about managing the most severe, we can then extend down to the people who are less severe. We're using a sit-to-stand test to work out who's hypoxic on exercising as a sort of a triage step amongst the most severe, but really nearly all of them so far, it is not that they desaturate on exercise. The predominant issues seem to be fatigue, depression, breathing pattern disorders, and deconditioning. And the management of that is very much self-directed rehab. We're happy to try and share some of those advice leaflets, but actually what we really want to go on to hopefully share is the app to help with this, but that's going to need some further discussioning at the commissioning level, etc. But we want to try and spread what we're learning so people can get the same in the community as much as possible. I think that's everything I had on my list to cover. The only other thing that just come up, they don't need to have a positive swab to go into the pathway. It's a clinical diagnosis of COVID. So we're not too concerned what the swab says. What we want to know is a clinical acute deterioration when the COVID first wave happened with COVID-like symptoms, and we will pick them up. And the final thing is a big thank you to everyone who's been involved. This is a very small list out of about 50 people who have been involved. Questions, I think.
Hi, Paul. Let me kick off. I know, thanks for reading the chat. That's made my job a lot easier. Yes, something you touched on right at the start. I know you said you were hoping to get those initial letters out to the hospital discharges at 9 weeks. Is that still the intention as soon as it's possible to do that?
It's the intention. We're just running 2 weeks behind, and with hundreds and hundreds of letters to go out, there's going to be a catch-up process. But if we have a second wave, hopefully we'll be able to kick to the timetable a bit better.
Sure. And so presumably you've modeled capacity issues. Do you have any idea? I mean, is the hope that, you know, with your streaming and stratification, you can take as many referrals as we're likely to send in?
That's the hope. I mean, what we've come up with is a pathway that can cope with large numbers as well as possible. I'm not sure there's ever going to be the capacity to cope with as many patients as we are seeing without massive resourcing, and we don't have the trained staff. Even if we could afford to pay staff, there aren't a number of trained people there. That's why some of this is going to have to be dissemination. As we learn what's going on, we need to disseminate that out. This is the learning phase at the moment.
Okay, thanks. And what you just touched on about the leaflets, I know a couple of other people have asked about that as well. Would it be possible to circulate those maybe through CDAT?
We can start to circulate them. Yes, I think we need to keep a log of how they're circulated, because if we learn more and we want to update them, there needs to be some governance process about how it gets disseminated. But yes, we can certainly think about that. Yeah.
So maybe not yet for that. That sounds reasonable. Yeah.
We probably can. We just need to put in place some governance process how we would update things as they change. And certainly in the hospital, we can't access your websites, etc., to update things ourselves, which has been a problem with other guidelines, which don't seem to disseminate as well.
Okay, thanks. And there was one question right at the start from Sheetal. I know. Sorry, I may have missed this in your talk, Paul, but I think I'm pretty clear about patients who haven't been admitted. If they're presenting in less than 12 weeks with symptoms post-COVID, we presumably would just do what we would do normally for any other respiratory assessment and possible referral. If a patient's been admitted and we're seeing them, say, at 6 weeks with symptoms, is there anything we should be doing at that stage?
So the case mentioned earlier was someone who'd been to an intensive care. They should have been picked up by the intensive care at around 6 weeks. It's a slightly odd case. If the details are fed back to the after COVID email address, we can attempt to tackle that one on an individual level. Yes, I suppose if the problems are much earlier, then they need to follow the normal pathway. So the very early complications seen about 2 to 4 weeks in some patients is PEs, and they have a stepwise massive deterioration, and they need to go to A&E and B exam in the normal way. The other more gradual processes here tend to sort of come on, but there isn't an urgency to deal with them at 6 weeks. But I so yes, I'm not too worried about that.
Thank you. There's a couple of other questions coming in. One about the anosmia and ENT, obviously that isn't part of the post-COVID clinic as far as I'm aware. Is that something we should be following up ourselves in general practice?
So again, we were expecting the anosmia to have got better in most patients by 12 weeks. It hasn't. We are writing an ENT smell nose advice sheet. Again, that's being written this week. We need to try it for a few weeks and we can then disseminate. There is good guidance about smell retraining. There doesn't look to be anything to actually do from a sort of surgical perspective. There doesn't look to be an intervention other than smell retraining. But again, we're working on that advice sheet, and once we're happy with it, we can disseminate.
Thanks very much. There's a suggestion from Isabel Hutchinson about possibly putting the leaflets on the WEL site, the WEL website, which can be regularly updated from there. I don't know what you think about that. And also a question for Rebecca. I don't know if you're still there, Rebecca. I think you are. I know in your talk you mentioned...
Yes, I'm here.
Yeah, you mentioned about patients self-referring to psychology. Do you have access?
Yeah.
Do you have access to that in all 3 boroughs for patients?
Yes.
Yeah.
I know in Newham they do take self-referrals, so I just wondered if you were aware of the process for all the boroughs.
Yes, it's in the advice sheet. We've got it for
Brilliant.
all the boroughs. And I think City and Hackney as well.
Okay, thanks very much. We've got another one here from Rob Jaffrin. Let's see. Okay, Rob, you better take that one yourself. That's well above my pay grade. Can you unmute?
Sorry. Yep. Hi. Hello. Can you hear me?
Yep.
Hi. Sorry, I'm just digressing slightly, but I was just curious to know, like, if those patients do badly or don't recover as expected, do you think that it might be correlated with the severity of their cytokine storm, such as interleukin-6 production, and whether these subset of patients have shown to benefit from interleukin-6 antagonist?
So the first bit of the question is easier. We don't know yet, but I'm hoping to run that analysis in the next week or 2. So again, because we're cohorting, we can run these analysis within the Barts Health statistics section. So we're going to be comparing the symptoms they get at 12 weeks to the inflammatory markers that we have measured. That should help us understand what's going on a bit more and about whether we need to worry about an organic underlying process. For example, if troponin goes particularly with memory problems, that might point towards more of a vasculitis. Don't know yet. In terms of an anti-IL-6, we are very far from knowing whether anti-IL-6 agents work. There are no good quality RCTs of that yet, even for acute COVID. It's only one of several different inflammatory markers, and we don't have very much of it. So it also wouldn't work down the line. We'd have to work out how we're going to deal with the consequences down the line. But again, it's a learning pathway, so we aim to learn and find out.
Sorry, yeah, thank you.
Sorry.
So there's a question come up from Sheetal. I think I can guess the answer to this one. It's about the duration of post-COVID lung scarring. Do we know? I'm guessing not.
We don't know, but certainly what I think, and I think Rebecca agrees, is lung scarring doesn't seem to be as big an issue as expected. We haven't seen lung scarring in all these people with horrible breathlessness at 12 weeks. What we're seeing is deconditioning and breathing pattern disorders in the majority. And the ones where other things are going on, there are clear indicators there are other things going on. So again, it comes back to good quality therapy and how we can do very large scale pulmonary rehab in many senses.
Okay, thanks very much. That looks like all the questions we've had coming in so far. We've still got a couple more minutes if anyone else wants to ask. And do you have any final comments? Anyone can unmute now. It's a free for all.
I think one thing that came up on the messaging was, would we cope with a second wave? The answer is yes, because we will triage out the most severe to see first. That's the way this pathway works. As many referrals as we get in, we can, in a sense, triage the most severe to always be seen first.
Was that someone?
Oh, hi, Duncan. It's Claire here, just from the home monitoring service in Newham. Hi, just because our GPs were planning to follow up all the patients who've been through the home monitoring service, which are the ones who are probable COVID but haven't been admitted. Some of them were referred to us from A&E. so we were going to do our own thing just to do some patient satisfaction and then check in and see how they were. And I know that when we discussed this with some of the CDs, the PCN CDs yesterday, a number of them said they thought that was a good plan. Would you want us to do the questionnaire, or should we use that as a framework? Or are you definite that, I mean, I think we should be a filter, and we should send in the people who are having problems to you rather than sending everybody into this service, this post-COVID service? Or are you wanting to have as big a database as you possibly can? And if so, do you want us to help you with that?
So it's a clinical service, very much not a research service. So I wouldn't encourage anyone to do the questionnaire who doesn't need to do it. For the research side, we need to make sure people are clearly coded in EMIS, etc. But that's a whole different question. If you're referring them in, we will send out the invite to the questionnaire. That's caused a little bit of problems, other people trying to access the questionnaire without the invite. I would just use your clinical judgment. But we're very happy, as we're more comfortable with the topic, to disseminate the ideas, because that might help you judge where to go with patients.
Okay, thank you.
There was another question around lung function tests and spirometry. I'm guessing this has been dealt with separately, but spirometry is being treated as an aerosol generating procedure. So to the best of my knowledge, there should be no spirometry going on in the community. But you need to wear full PPE and have air changes where you're doing it. We're doing very little in these patients because of that. And again, it doesn't seem to be the biggest of issues.
Yeah, that's still the case in Newham as well. People are being encouraged to, but I think the main issue is for potential new diagnosis of COPD, and we're encouraging people to do that clinically at the moment. Okay, I think that's about it. It's just almost 2 o'clock. That's perfect timing. Thanks very much, Paul and Rebecca. If there's no other questions, then we'll wrap it up. You're welcome to leave. So, I'm sure Paul and Rebecca won't mind hanging around for a little bit longer if there are any other questions still ready to come in. Maybe you didn't want to ask them in front of 100 people, but far away now. We'll still be here for another couple of minutes. Thanks very much. Yeah, Paul, so thanks for that.
It was good. I do think we need to think about down the line whether we do a webinar about deconditioning and breathing pattern disorders and those other types of issues. I don't know how much is known about them in primary care. And
I think that would be useful, definitely.
They've sort of been slightly ivory tower topics.
Can I ask a question?
Oh, sorry, we've got a question coming in. So I didn't see who asked that. Can you
Hi, it's Dr. Gavin here. I just want to ask a question. In the e-referral, what is the actual clinic called? Is it called post-COVID lung clinic?
It's on the slide deck. It's called post-COVID or after COVID. I can't remember which one we went to.
That's great.
I'll just look it up. I'll look it up too, or have you got it?
We're trying to use after COVID as more patient-friendly language.
After COVID. Okay, that's great.
But
thanks.
On ERS,
all this anyway.
Post-COVID.
After COVID. Okay, thanks ever so much.
Yeah, sorry, carry on, Paul.
I mean, I don't know whether things like breathing pattern disorders are slightly ivory tower diagnoses. They shouldn't be. We're developing new tools to diagnose them, which are ever easier. I think someone's got their hand up as well.
Yeah, I think Shahid had up.
Hi, good afternoon. Thank you for that. Fascinating, and it sort of gives me a good idea of what the state of play is with respect to COVID. And I have to say that I am seeing a few of these folk who have managed to survive COVID in the community coming back to me again and again. I have referred them through the e-referral service. It was relatively straightforward, and they were quite happy to go up to WIPS to get their chest x-rays done before that. My concern is not necessarily, and probably for the second half of the lockdown, hasn't been COVID itself. My main problem is that I am hanging on to a large number of people with quite nasty respiratory conditions that aren't COVID. And I'm just a little bit concerned, especially as winter is coming, how we're going to cope with these things. There are plenty of other things out there in the world of respiratory medicine that can kill people or maim them. I'm just trying to figure out what sort of, whether there are any changes to how we will manage these people over the coming winter.
So, in terms of resources, the after COVID clinic, which Rebecca is very much leading on, is extra staffed, as opposed to the rest of the respiratory outpatient work, which should now be all restarted though much of it being done virtually. So the normal referral pathway should be open as far as I'm aware. Mine certainly are as far as I'm aware for asthma. So we try to balance the resource that way by cohorting these post-COVID problems. We've got the second issue of how to diagnose diseases. To be honest, I think a lot of our diagnostic tests were never as good as they could have been in the first place. I think a peak flow diary is still a key way of diagnosing asthma to my mind, and a trial of treatment. Again, these could be a very good series of conversations we can have, how to diagnose these diseases without lung function studies. But you're quite right, this winter, if we have a second wave with flu as well, is going to be scary. We were very lucky that flu ended a month early this year and had cleared before coronavirus came along.
Thank you.
Still keep forgetting to unmute. Yeah, so no, I think that's, otherwise we've had a bit of good feedback. Rebecca said you're getting a few GP referrals in now from post-COVID symptoms, but still the vast majority is post-admission.
I've accepted, I think it's about 60. I've not kept a record, but the 60 ish referrals, there seem to be about 5 a day that I'm accepting at the moment. And then it's just the admin, and I'm sort of, I've had some come back to me within about 2 to 3 weeks by the time all of the other stuff takes place. So it's quite quick once after it gets referred.
And can I ask Rebecca what you're doing for inappropriate referrals then? What's your pathway for that?
Letting Paul reply.
We've had very few inappropriate referrals that I've spotted. People have been very good. They are referring patients who have had COVID symptoms. Mm-hmm. If we then review it and decide actually this really needs a specialist review at a different part, as COVID has brought up lung cancer, our pathway will slot into that. It's designed to do so.
Right.
I think we've only had one referral which was inappropriate, and that was partly because a CT scan report was potentially misleading. We have passed that back to the GP and said the lung issue is not as pronounced as reported, and there looks to be a separate cardiac issue that is not COVID related and therefore needs a different referral.
Okay, and did you send that back as a rejected referral with a comment, or did that go back by email?
Rejected referral with a comment.
Okay, I think that's a really good way to do it, actually. I think one of the problems we have in general practice is that quite often we get rejected referrals without comments. But I think if it comes back with a reason and a bit of advice if appropriate, I think that's a perfectly good way of doing it, really.
Yeah, just the one thing to highlight is out of those 60 that I've done, very few had a possible COVID date on it. I should have made it up for our pathway, but yeah, hey, can work around it.
Yeah, I suppose because there isn't a pro forma really, I suppose it's going to be hard to flag that up.
But I mean, the data is quite key to looking at the natural history, particularly things like PTSD. Yeah. The questionnaires don't work if they're done too early, and we can cause more harm than good if we do them at the wrong time.
Yeah, but just to add to that, I'm certainly not advocating another pro forma. We've got far too many. I think, but I suppose it's just a question of continually getting the message out. Maybe that's something the CCG can send out just as a circular, just in one of their regular information updates about the clinic.
What do people feel about the app primary care buy-in? If we're going to get the app moved out to primary care, we're going to need support and probably a bit of commissioning support in particular.
Kate, are you still there? I know you were here earlier.
I think that's a really good idea, but obviously we need to get discussions with primary care clinical leads and LMC buy-in, to be honest with. So I think that's worth a conversation. I have been trying to get the LMC to engage, but I will send an email. So if you can put your request in, I will try and remind a few people just to get in touch again, and we can have that conversation.
Good. Thanks, Kay. Sorry to put you on the spot.
No, that's fine. As long as there's buy-in from primary care and we can have a discussion between primary and secondary care with all the issues, and we can discuss any problems initially, I don't think that should be a problem.
Great.
I think the bigger issue from our point of view is we'd like to go to Barts Charity to potentially fund rebuilding of the app to make it more friendly. Barts Charity would always appreciate letters of support for people about anything we can do with an app, numbers, bridging the digital divide. We don't really want primary care to have to pick up a large bill. It'd be much better for a charity to do so.
Good. Okay. I think we're probably done actually, Paul. Thanks for hanging on for another 10 minutes or so. Is there anything else you wanted to say, Rebecca?
No, except I've got to go now and see some patients.
Fantastic. Okay. No,
right, thanks, everyone.
Yeah, and thanks for that, for organising it.
Thank you, everyone.
Can I just say thank you to everybody? Thank you to our speakers, Dr. T and Sedat, for organising. Thank you.
Thanks, Kate. Speak to you soon.
Bye-bye.
Bye now. Thanks, Paul. See you then.